In 2024, Minnesota saw its first major reduction in overdose deaths, with a statewide decrease of 26%. But despite this progress, most Minnesotans seeking treatment don't have access to the national gold standard of care for patients with opioid addiction, medications for opioid use disorder, or MOUD. While naloxone can reverse an overdose by kicking opioids off their receptors in the brain, buprenorphine blocks and partially activates them enough to reduce opioid cravings and ease painful withdrawal symptoms. When dopamine levels in the brain become out of balance from repeated opioid use, MOUD restores them, empowering patients to focus on their own health goals and succeed in daily life. To help meet the need for these medications, with federal funding from the CDC's Overdose Data to Action grant, 5 Minnesota hospital systems have teamed up to expand low-barrier access to MOUD in emergency rooms, changing the way they interact with patients and collaborate with local partners to provide the best care they can.
Most addiction medicine clinics operate on an appointment-only basis, Monday through Friday, daytime hours. Clinicians and nurses are at an all-time shortage, as you know, across the United States, and especially in the rural setting. The great part about the emergency department is it's all over the state. It's in rural, urban areas. Your ED can function 24/7 as that open arms place where patients can stop by and figure out what's the next step for them.
So one of the things that people probably don't realize in the emergency department is that literally just one dose of buprenorphine can change the whole trajectory. So there are 3 different medications that can be used for opioid use disorder: methadone, naltrexone, and buprenorphine, or bup. But because of so many reasons, especially safety and some of the data for buprenorphine, that's always been the go-to. And that one dose, that first dose, whether it's oral or it's injectable, literally decreases their all-cause mortality. When do patients overdose most frequently? It's really when people leave the hospital, whether it's from being in the emergency department or even from the hospital where they've been in withdrawal. So it's important that when they leave the emergency department that they're actually on the medication, not just prescribed it, but they've actually taken it.
So bup is great because it's not as restricted as methadone. So any of my emergency medicine providers can prescribe it at discharge, and we can start it and initiate in the ED.
We have the ability to take patients from a state of opiate withdrawal, which we have heard people describe as it feels like your soul is being torn out of your body, and give them a simple medication, and they feel better within minutes. And it is our duty as providers to care for these people.
When we think of just sending someone to chemical dependency or substance use disorder treatment, the chances that someone remains sober with opiate use disorder at a year are pretty low, about 10% or less. Medications for opiate use disorder enable people to live normal lives and importantly, keep them alive.
Post-overdose is, I think, one of the most important times to be able to talk to a patient about how severe their addiction has become. We were fairly early adopters to be able to, one, provide buprenorphine in the emergency department, but also to be able to send patients home with buprenorphine directly from the ED and not having to go to a pharmacy beforehand.
We know that after an overdose, people are in withdrawal. The most successful treatment is to put people on medication for opioid use disorder, and they're able to organize their life. It gives them an opportunity to learn something about their illness. They get an experience with using MOUD. It makes them feel a little bit better, and so maybe some motivation to get into recovery.
And the reason that buprenorphine helps is because it kind of hits that part in the brain that needs it, but it doesn't knock you out and make you totally sleepy so that you can't function anymore. And that's a special property of that medication.
So when you take an opiate, you get sleepy and you get sedated and you don't breathe as much. Opiate withdrawal is the opposite of all of those things, right? You have diffuse body aches and horrible joint pain. You're incredibly restless and irritable. You have profound diarrhea, often nausea and vomiting as well. Patients describe it to us as the worst possible feeling you could ever imagine. We have to feel comfortable caring for those withdrawal symptoms, not through a Band-Aid of a bunch of medications that kind of address the symptoms, but using the one medication that we have that will actually make them feel better, and that's buprenorphine.
To get this life-saving medication to more people who need it, medical providers are adopting low-barrier approaches, like same-day access to medication and prioritizing patient engagement over a strict adherence to appointments or protocols. Anything that improves access, builds trust, and respects the unique needs of each patient.
So meeting our patients where they're at. You can't always get into a clinic at 9 a.m. There's not a lot of walk-ins, and there are not enough addiction doctors out there to help with this problem.
In many places, you have to be on time for your appointment, and if you're 15, 20, 30 minutes late, people will say, well, you have to reschedule. Well, in the recovery medicine clinic, if you come on the day of your appointment, man, you're on time. And if you come on the day you're not in, it's not your appointment, well, you can wait in the waiting room, and we'll get you in, and we'll see you.
A lot of times we might have a patient even come in a different door of our clinic, so they might come in for SUD outpatient treatment, and one of our LADCs will say, you know, we do have medication for opioid use disorder, and we might get a referral that way. And so we have a lot of kind of front doors, I would say. All of what we do is these are some options that we have for you, and we would, you know, love for you to consider them. What do you think fits best with your life? What do you think fits best with your specific needs?
The nurses really set out to take really good care of our patients. I really like to take time to make sure that we connect with them on a personal level, like how did you get here? What resources do you have? What's your support system? Well, and the reality is they are met with stigma. You know, they enter the door and it's societal, but it's also in our health systems that we have these patients that they're really there to save their own life and they know it. But does the healthcare system know that? Do they know the adversity that they face walking through the door? And how they contribute to it.
We hear that from the community. Patients are afraid to go to the ED for their cellulitis or their chest pain or whatever it may be, because they know they're going to go into opiate withdrawal where they're there, and they don't know how they're going to be treated and managed. So when I see a patient and I see they have opioid use disorder, I will just bring it up with them like, hey, do you think you're going to go into withdrawal while you're here? It's going to be a 12-hour wait waiting for a bed. If you do, please let us know. Here are the options, and I just lay out the options right off the bat, right? We can do bup, we can just do symptom control, we can have addiction med come see you while you're waiting, whatever you need, but you've just got to name the elephant in the room, because there's no way you're getting someone to be admitted to the hospital for their cellulitis if they're in Florida opiate withdrawal and you're not managing it. They will 100% of the time leave because they don't trust you and they feel like their soul's being ripped out of their body and their cellulitis doesn't matter anymore.
The same stigmatization that exists in the community also exists in healthcare providers.
Absolutely.
And unwillingness to learn about this medication compared to like 25 years ago. Like we now know that addiction is a chronic progressive brain disease. And just like any other chronic progressive disease, it is preventable and treatable. There's some wonderful providers that keep up to date on this stuff. There's also a lot of stigmatization still very pervasive.
If you have any questions about it, feel free to reach out to other systems that have implemented it, but I think it's definitely something that all EDs need to be considering.
The stigma that surrounds opioid use disorder has always been pretty amazing to me. I think everybody wants to look at this as some moral failing or some huge problem that they don't have. And the fact of the matter is that still probably a third to a half of the patients that I see were given their opioids by a physician. And so their addiction was actually started by the medical system itself. I think back in the days when HIV was coming around, everybody was very afraid of HIV because they didn't understand it. And literally we're afraid of buprenorphine because it's a different kind of medication, it works differently. It's the fear of change and the fear of a medicine that they don't understand.
But I would like every physician to feel comfortable using these medications so that anytime any one of their patients has a problem like this, they can just start the patient on care or receive them from the emergency department. Not only do we need to get the ER up and running with providing MOUD, but we need to establish the capacity in the clinic in that community to be able to continue those medicines.
Where's that patient going to go from their ED? Are they going to drive 100 miles to Duluth or 200 miles to St. Cloud? Maybe not. And if we, again, look at the statistics that more people die when they leave a hospital of overdose than even jails, that even the thought of having somebody leave without buprenorphine in my mind, is probably malpractice. And so I do think we need to really, as a state, we need to up our game.
I think one of the unique things that Allina has done is telehealth. So say I'm taking care of somebody at Abbott Northwestern, but they live more rural. They may not have a Suboxone prescriber out there. I can place at discharge to refer to our licensed alcohol drug counselors to do their assessment and kind of get patients to the next steps.
If your health system or your EMS agency or your clinic becomes that safe space, you will have patients who seek you out. Our ambulances, for example, we've had patients knock on the back from while they're just parked drinking their coffee and waiting for the next call and say, hey, can I get another Narcan kit? We gladly hand them out. There are plenty of community resources and foundations that will help you get those stocked in your emergency department for little to no cost if you need them. There's the Minnesota Department of Health and Naloxone portal. And so there's plenty of ways in which you can do that with very, very low barrier to meet the patients with what they need.
It takes a couple of champions locally to start doing it. And it's like any evolution of care in healthcare or in emergency medicine. You don't want to be the person who's practicing the old style of medicine, right? So you have to slowly change the culture in your group. And you need institutional support, right? We need to have buprenorphine available. Having order sets are really helpful. Discharge order sets are really helpful. You've got to lower the bar for people to engage in this type of work.
If you look at the students that are coming out now from medical school and residencies, they're learning how to do this. And so I think we're going to see in the next 5 years, it's really going to improve. But it couldn't go fast enough because people die every day.
We kind of found this idea of this like mini champions in different areas, different hospitals that want to start this work, or clinics that want to start the work to find out what they're doing in their region and what they're seeing in their region. We've gotten more services out even in the Fargo area because of some of the work that we've been doing in Bemidji. So all of those things have been, I think, as a result of this collaborative effort through the OD2A grant.
I agree completely, Mindy. You know, the collaboration between the different health systems as part of the OD2A grant has been of great benefit with all the partners. So today we're here at the Rural Health Conference in Minnesota, and myself and Kurt Devine from CentraCare and Cole Perringer from Essentia explained our systems and the things that we're doing to try and encourage other people to participate in the same way. And so there's been a whole bunch of cross-pollination that's happened. More, you know, I've been a doc for a long time. I'm an old guy, and this is the best collaboration between those health systems I've ever experienced. So that's good.
The biggest barrier always is change, right? How many EDs in our state are actually treating people with bup in withdrawal or overdose? It's a very small number. But again, it's getting the word out. It's having patients know now that they can go to the ED and actually get treated.
Yeah, it's really about combining just empathy for patients, just as you would for anyone coming into the emergency department, with good care. I feel like these patients deserve that same level of care, and I'm hopeful for it.
There's nothing that gives me a greater honor in the entire world than to walk with somebody, into that recovery and watch all the things start to happen for them and them just come alive again. Medication for opioid use disorder does that, and that services and treating people with dignity and respect and compassion and understanding, that really is the key to helping people, start to recover their life.